Good afternoon, everyone. I'm Dr. Sriniadaklon. I'm the Chief Instructor for this session. This is Dr. Umesh, Dr. Kaushik, Dr. Prabhushankar, Dr. Vanati, and Dr. Gopal will join us there in other sessions. See, the session we have planned basically to discuss on the medications that we use perioperatively in cataract surgery, preoperatively, intraoperatively, postoperatively. So there are different scenarios that and different types of medications that I use that we are considering. One is anesthetic drugs. Then you have the topical steroids and NSAIDs, perioperative antibiotics. Then you have how to manage the anti-glaucoma medications perioperatively, improving patient satisfaction, because how to manage the dry eye and all, and anti-VEGF agents, and finally the medical management of posterior segment complications. We'll start with Dr. Umesh. Dr. Umesh is Chief of Shankara Eye Hospital, Bangalore. He's a prolific anterior segment surgeon, cataract and refractive surgery, and he'll be speaking on anesthetic drugs and mydriatic agents, topical and intracameral. Umesh.
Good morning, everybody, and thank you, Dr. Srini. I think this is a very simple, basic instruction course, which most of us underestimate and undermine and look over, because these are very simple things that we do in a day-to-day practice, and sometimes these are the simple things that we overlook, and that is where we want to make sure that this should not be overlooked. So I'll be talking about the anesthetic drugs and the mydriatic agents and what is the latest that is happening. All of us know we have been using this time and again, and every day it's our daily, it's just like a bread and butter, and most of us don't even look into the so-called side effects of all those things, though and many studies have proven that even in hypertensives and all, we can safely use all these things. Occasionally, on some occasions, you do end up in allergic reactions, and this is where we have to know where the allergy comes from, what is the allergy is due to. And most of the time the culprit is phenylephrine, and enough studies have proven that phenylephrine is the most common cause in our T+ that we normally use, and it causes simple blepharoconjunctivitis to severe blepharoconjunctivitis, and all of them resolve without any medical intervention. And obviously the first step is to stop it, and they are basically delayed hypersensitivity reactions. The few of the tests where they specifically did, obviously they were used tropicamide, phenylephrine, and the anesthetic. They did a spin prick test and saw that the tropicamide did not respond. It was the phenylephrine. So most of us, what we do is, the moment we see an allergy to T+, we stop T+ and move to cycloplegics, that is cyclopentalate. Probably it's worthwhile to look at tropicamide, because that gives a better and a shorter duration cycloplegic effect, both for surgery and for your refractions. Cyclopentalate also is used with the complications that mostly we see in the pediatric age group, because that is where we are extensively using. I searched the whole net, and just to find out that there was only one case report of delirium in adults. So basically, safely you can use, that should not be a problem, and only in such such patients you look for. Last year, I think we had one case like that, but they are all self-limiting and they get over very easily. Now the interesting part is the intracameral mydriatics. I think most of us have been using this, and I want you to understand the importance of this, using this intracameral. The two things that are available are intracameral epinephrine and phenylephrine. Epinephrine is always an off-label drug, and the epinephrine is always available at 1 in 1,000. And the advantage of epinephrine is it acts both on the alpha and beta, so the action is very fast and more rapid pupillation. But the problem here is the potential for corneal endothelial damage and obviously cystoid macular edema when the higher concentration are used. So this is where you have to be very careful. Epinephrine is an off-label drug. Don't depend on anybody. Have your own schedule of doing it, and understand what is the problem. So most reports have shown that anything more than 1 in 5,000 helps a better this one. and doesn't have any corneal damage or cystoid macular edema. See, some different studies have quoted different things. The major thing they said was two things. One is the sulfite, bisulfite preservative that will be used in epinephrine. That is one of the cause. And the other thing is the pH. The pH of epinephrine, if you look undiluted, it is around 3.5. What we need in the anterior chamber is around 6.5. So you ensure that you need to dilute it. So dilution is the most important factor. So especially when you are doing the surgeries, you are having a complication, you ask the sister to give, sister gives you directly from the vial, you are done. I have had this experience, that is why I'm telling you. I burned my fingers, and from that day onwards, I'm even hesitating to even do use any intracamerals. But provided you monitor and you ensure that so what we are using at our center is 1 in 1 lakh, that is 0.1 ml of epinephrine and 0.9 ml of BSS. Nicely shake, observe, take your time, and then inject, you're safe. So though some of them have shown that the damage was because of the sodium bisulfate preservative free in India, I don't think it is available. I've searched everywhere, it is not available. What is available with the bisulfites? But if you can dilute it, the intracameral, if you can dilute it to more than 150,000 or 1 in 1 lakh, you're safe, you can use, though it is an off-label drug. The ones, the topical anesthetics that are available, and most of us are doing topical anesthesia we tried initially with topical paracaine and lignocaine. This is our standard protocol now. Both paracaine 1 drop and lignocaine jelly slightly, and after 3-4 minutes immediately. The only thing you have to be, especially if you have a long list, so make sure that you don't put well in advance, because once you put well in advance, they start stopping blinking because the reflex is lost, and you end up in a surface epithelial edema. Especially those who have done many topicals, you will notice that. So be careful. Some of us have now shifted. If you have a long list, any working institutions long list, you put, then patch off immediately, so that they will not keep the eyes open. Or some of you on table, you can put that and do. Many studies have shown that this is a Cochrane database of systematic reviews that has been done to compare both topical as well as intracameral versus only topical. And the pain scores, the complications, everything has to be more or less same. So we at this point of time feel that if you are well versed with topical and just a drop of paracaine and jelly should more than suffice. And for those of them who are literally having too much of movements or having iris pain in between, if you want, at the most you can give a 0.5 ml of, not more than that, lidocaine intracameral if you want to use. But most studies have clearly shown that there is no, it can be used in adjunct, but it has no undue advantage. Now, all these times we are only talking about the off-label drugs. Now, we are now getting the commercially available. I think this is the only one that is available, and understand none of the commercially available drugs have epinephrine. They have only phenylephrine. Phenylephrine usually has only the beta blocking effect. It doesn't have the alpha, doesn't the beta, whereas epinephrine has both alpha and beta. But somehow, for obvious reasons, phenylephrine is the only one that is available, and most of the fast surgeons are now slowly shifting to that. I think I'll discuss about the dropless cataract surgery later. The other one that is available commercially is Omidria. Omidria is essentially phenylephrine and Cataract. So you have the pain relief also during surgery. Are, and this is FDA approved. Both of these are, as of now, FDA approved. For some of us who are actually institutes where doing high volume surgeries, slowly we are now converting to subtenance. This is just, I want to put a word or two about the subtenance because it's literally catching up. Those who are practicing peribulbar or retro, I would suggest you to slightly shift to this subtenance, a very easy technique, just 1 ml or 1.5 ml into the superior fornix, make a small nick, take a special needle, go inside and inject. Wonderful, no lid edema, no chemosis, and absolute. And if you keep doing, I think some of the bigger institutions, they're even doing in the camp sections, that is Arvind has completely shifted. We are also in the process of shifting completely to subtenants. So in between cases where you have a problem and you have to shift, probably this is a very good option for you to look at. And it is a very simple process. And once
right
one or
side.
two you get hands-on, you should be able to
Left
do that.
side.
Even if you observe, I think if you can go ahead and do. And we would recommend you to shift slowly towards subtenants. And most of the studies are showing that subtenants. I think we are not far away from what we call as a dropless cataract surgery. Now, under investigation are two specially prepared compounds. One is trimoxy, that is triamcinolone with moxifloxacin, and the other with vancomycin. I think the patient is going to just walk in. So then you put your phenakine plus, which has adrenaline, dilatation, and all these things. And at the end of the surgery, you put this. So preoperatively, no drops. Postoperatively, no drops. The day is not far off. Probably all of you will have to shift to this and make it a dropless cataract surgery. That's the newer advances. I think it's slowly, once this gets the FDA approval, probably you're all going to get into that. Thank you. And I think...
Thank you, Umesh. We'll have the discussions at the end. Next, I call upon Dr. Kaushik Murali. Kaushik Murali is the president of Shankara Eye Institutions in India, and he's going to talk about perioperative antibiotics, oral, topical, intracameral, and in BSS.
Thank you, Dr. Srini, for inviting me to be a part of this IC. It's almost become an annual ritual for us to look at varied topics that interest ophthalmologists across spectrum of clinical care. Okay, it says my time is already up.
No, that's okay. That's okay.
Yeah. So I think it's what Dr. Umesh has alluded to kind of sets up what I wanted to talk about. In terms of perioperative antibiotics, he showed about the dropless surgery where you're having triamcinolone with vancomycin or with moxifloxacin. So there is a tendency for us to use a lot of antibiotics because we are paranoid about infections. When you look at it from a percentage standpoint, it is not too much. We talk about 1 in 10,000 or 6 in 10,000. You talk to an orthopedic surgeon, they probably have a lot more of infections happening. But the way the patient presents to us, and I think the onus that we've put on ourselves in terms of visual outcomes puts pressure on us to make sure that this doesn't happen. There are various causes that have been attributed to infection, right from instruments to solutions to contaminated tissues that have been used. But by and large, most studies have shown that it's the patient's normal flora of the lid and conjunctiva that are the most common source of microorganisms. When we're using prophylactic antibiotics, we need to be careful because you could have toxic and allergic reactions. There is a cost involved. Most times the insurance companies don't cover that. There is an alteration of the protective flora, so you don't know whether you're going to introduce an infection or induce an infection because of your intervention. And always there's a fear of over-medicating and creating some kind of a drug resistance. Again, we don't know the efficacy. Does it change from ethnicity to ethnicity? Most studies have been done in Europe or other parts of the world. Very few studies out of India. That is changing, fortunately, now. And there's a discrepancy between what happens in the lab or what our pharma reps show us and what our own personal experience in the clinic is. Among the organisms that have been isolated across India, most common continue to be the gram-positive species, such as the coagulase-negative staph, the streptococcus, and the staph aureus. Less common are gram-negative, Pseudomonas and Haemophilus, and rarely you see fungi nocardia. Again, the caveat is certain geographies you would see more of nocardia. I'll come to that. You're more likely to see nocardia probably in Tamil Nadu. That has been our experience across our centers, and we have specific interventions to that. So it's important for you to talk to your colleagues in your city and understand what organisms are commonly seen. Most of them will not publish results, but in a hall like this, just chat with your colleagues around and understand what's happening. Topical antibiotics are preoperatively or perioperative. The evidence is not very compelling. Theoretically, it is supposed to reduce the conjunctival load, but again, there are various reviews that have shown it is not very effective. The ACRS study of 2021 said that in case you're starting off on topical antibiotics, it's better for you to start off a day early rather than on the day of the surgery. So if at all you're looking to start patients, start it a day early. a lot of us during our training period used to give subconjunctival antibiotic and steroids almost as a standard. This is not something new. The first literature that I could find was as old as 1956, where Perlman showed that they looked at subconjunctival antibiotic of about 2 lakh units of penicillin G. But then again, there were various other studies that said that it kind of delayed the onset of infection, and patients are usually lost to follow-up. After about 4 to 6 weeks, they assume that the infection has nothing to do with the surgery, and the outcomes again were very, very poor. Subconjunctival tobramycin has been used very commonly across India. That used to be something that we used to do routinely till a while back, and it was found that it worked very well against protecting against Pseudomonas, and it gradually disappeared from the eye after about 8 hours. Systemic antibiotics, again, by themselves probably do not have a role. So again, we come from a system where we used to routinely give doxycycline for 2 days. Again, the premise was that somehow it reduces the lid flora. We found a lot of emotional response in that whenever we put a patient on doxycycline, some strange reason the end-off rates used to be low. And whenever we used to stop reviewing literature, the rates used to go up and we used to go back and start it. Currently, we've stopped it. There is no real benefit of using this because there's very limited ocular penetration. But what they've shown is that wherever intracameral antibiotics are used, if you combine topical antibiotics, probably there is an additive effect. So that again, the Cochrane review has said that this is probably the way it can be used. So if at all you're using systemic antibiotics or topical antibiotics, it should be along with an intracameral drug. Balanced salt solution, should you mix anything into it? So Dr. Umesh spoke about the corneal damage that can happen. When you're using anything in a balanced salt solution, there is more repeated exposure to the eye. And again, there is a worry as to what could go on. We don't know how much it really works. They've used various drugs again in the eye, from vancomycin to gentamicin, where comparatively they've compared it with just BSS and shown that the incidence of endophthalmitis is very low. Again, there are studies where they've shown that topical povidone iodine results in low endophthalmitis rates. In ESCRS, again, there was another study where they said that just painting is good enough. You don't need to really look at anything extra. And again, the meta-analysis shows that adding in drugs to your BSS may not be a great idea. Because again, this probably are dependent on your assistant doing it. And when they're injecting a drug, are they even cleaning off the surface? Or are they introducing an organism into the BSS is a bigger concern. So I did mention to you that specifically we've been using amikacin in Tamil Nadu. Both our hospitals, we've been using this because we had a spurt of nocardia that kept happening. So almost about 20% of our endophthalmitis that we were reporting were nocardia species. So again, we did a literature review and we found that amikacin was very effective, between 8 to 16 micrograms. So we took the 2 ml amikacin vial that contains about 250 milligrams, and we took about 0.1 ml and added it to 500 ml of BSS. This results in us getting about 0.02 microgram or 25 microgram per milliliter, which is much more than what has been published. Ever since we've introduced this, we've had almost a zero nocardia endophthalmitis across these centers. So you need to again understand what organisms are there and see whether the antibiotics you're using are actually useful or tweak it a little bit. Now, most of us have moved to corneal incisions and almost scleral corneal incisions. We know that there can be an influx of fluid during the surgery even after hydration. And contamination has been noted in almost about 1/3 of cases. And this is similar both in phaco or manual SICS that we may be doing. So injecting antibiotics intracamerally is intended to kill the bacterial microbes that have been introduced. And there is, again, enough literature to say that this one-time intervention, you may not be triggering an antibiotic resistance. Again, intracameral, various drugs have been tried. Polymyxin B and neomycin has been discontinued due to toxicity. Payman introduced intracameral gentamicin in a large camp setting in South India, incidentally. This was the first published study to explicitly take culture to confirm. That's the interesting part of the study. But again, they found a lot of false positives. So they don't know whether it was contamination because almost all of them, all the 18 patients miraculously recovered. The largest prospective study was the ECRS study that was first published in 2006, where they showed a significant drop in endophthalmitis with intracameral cefuroxime. Now, various drugs that can be used, cefuroxime, vancomycin, and moxi. Cefuroxime, the fear is with worst outcomes resulting in post-intervention end-off, where commonly Enterobacter has been cultured. Vancomycin, again, there's a fear of hemorrhagic occlusive retinal vasculitis. This has again been reported across the world. Moxi has been pretty good. It has become the mainstay of most intracameral because it is more bactericidal for a much longer period of time compared to cefuroxime. Again, a lot of us use either the off-the-counter Vigamox that is available. Again, no financial interest. Why Vigamox? Because it is unpreserved, so it is much more popular and it is much safer to use. If you're using any other brand, confirm that they don't have preservatives because you don't want to be introducing a preservative into the eye. Intracameral does not prevent gram-negative infection, but however, what has been noticed is wherever it has been reported, the symptoms and signs are much milder than the classical description that you would see with a gram-negative infection. So here again, a short video that shows how we go about mixing it. Typically, we take about 3 ml of the Vigamox that comes, draw it into a syringe that has about 7 ml of balanced salt solution into it. So effectively, the 10 ml of diluted Vigamox that you have has about 15 milligrams of moxifloxacin, and you take about 0.1 ml or draw it again into an insulin syringe, and you would look to inject anywhere between 0.3 to 0.4 ml. Why 0.3 to 0.4? You know your anterior chamber has about 0.4 to 0.5 ml, so you're trying to replace that entire content. Typically, when you're injecting it, you want to inject it in the anterior chamber as well as in front and behind the IOL. This is a video of one of my colleagues injecting it into the anterior chamber through the side port. So most commonly, we would do that. A lot of us who do manual SICS at the end of the hydration do inject it through the main section. We've not been able to prove that it remains in the eye, but we believe that because you're injecting 0.4, it flushes out the content and the bacterial load should come down. The other alternative is this technique that we found where we use a 30 gauge needle and do a stab entry. So where you don't want to really put a side port or you've not used a side port. We've tried various from 24, 26 and 30 gauge. We found the 30 gauge to be most effective in terms of an ability to seal the wound. So you can directly just stab it in, inject it at the end of the surgery and come out. So it kind of is a self-sealing kind of an incision that happens. So intracameral has come a long way. There are 3 surveys done by the American Society of Cataract Refractive Surgeons, where from about 77% of respondents not injecting intracameral, it has now come to about 83% of them looking at injecting this. So I think it is here to stay. It is a very good tool for us to use as cataract surgeons as a part of a cataract surgery. So once again, thank you, Srini, for inviting me to be a part of this.
Thank you, Dr. Kaushik. The next talk will be by Dr. Srini. Dr. Srini is the Chief Medical Officer of Comtrust Hospital, Kannur, and also a very big participant in the Kerala State Ophthalmic Society Scientific Committee. He's the Chairman Scientific Committee. He'll be talking about the perioperative anti-glaucoma medications in cataract surgery.
Thank you, Mish. See, during cataract surgery, there are many instances when you have to initiate or modify glaucoma medications preoperatively, intraoperatively, or postoperatively. When you consider these scenarios, these are the situations to be discussed. One could be IOP related. The other one is non-IOP related. The intraocular pressure related situations include lens-induced glaucoma, postoperative glaucoma, patients who are at risk of glaucoma, pseudoexfoliation or ocular hypertension who are not on anti-glaucoma medications, and obviously glaucoma patients who are well controlled on topical anti-glaucoma medications. And there are some situations in which we are not targeting the intraocular pressure, like cataract surgery in a small eye, eyes with poor endothelial status, and in which you feel that the endothelial count might come down after a cataract surgery, like phaco and hard cataract. In lens-induced glaucoma, there's definitely some inflammation, and you have to manage the intraocular pressure as early as possible before you go ahead with cataract surgery. So prostaglandin analog, which induces inflammation and which doesn't act that fast, need not be used. The same thing with postoperative glaucoma. It's better to, because there is inflammation, it's better to avoid prostaglandin analogs if possible. So pseudoexfoliation. When you do cataract surgery in cases with pseudoexfoliation, it has been seen that postoperatively, in the first 24 hours, there is a IOP spike. And studies have shown that giving oral acetazolamide 1 hour before surgery reduces the postoperative intraocular pressure spike. So if there is no any contraindication, it would be a good idea to give oral acetazolamide in all cases with pseudoexfoliation 1 hour before cataract surgery. Now, why should you discuss usage of carbonic anhydrase inhibitors and perioperatively in cataract surgery? See, the corneal endothelium has got this carbonic anhydrase 2 isoenzyme there. So obviously, carbonic anhydrase inhibitors can adversely affect the functioning of corneal endothelium. But the study has shown that this carbonic anhydrase facilitates ion transport impacting that mechanism in the corneal endothelial function of many species, but not the human corneal endothelium. So it supports the clinical observation that you don't get corneal edema when you administer carbonic anhydrase inhibitors normally, and it suggests that there is an alternate ion transport mechanism that may be operational in human corneal endothelium. And also lots of studies, including this, have shown that use of brinzolamide in addition to latanoprose has no influence on the corneal endothelial cells. So carbonic anhydrase inhibitors may be safely used perioperatively in cataract surgery. So now coming to the endothelium. See, you have hard cataract where the phaco time is more, you have a lot of fluid going around, chattering and all, and the cases with poor endothelial status initially. So there should be a mechanism to protect the endothelium. So can the ROCK inhibitors protect it? This study that was published in 2021 by Fujimoto et al. Concludes that the ROCK inhibitor, Ripacidil, shows an endothelial protective effect in patients with low corneal endothelial density after cataract surgery. So they had two groups. One group had Ripacidil 0.5%, I dosed twice daily after cataract surgery, and the other didn't have. So the mean rate of increase in the thinnest corneal thickness, that is corneal edema, 1 week after surgery was 1.25% in the Ripacidil group, which is significantly lower than the 5.97% increase observed in the control group. So the conclusion could be that the Ripacidil may help maintain the corneal endothelial functional integrity and reduce cell loss after cataract surgery in patients with low corneal endothelial cell density, suggesting that it may be broadly used for protection of corneal endothelium after cataract surgery. But you have to consider this also. There have been various reports of corneal honeycombing or reticular corneal edema occurring after the use of another ROCK inhibitor, Netrasidil. So this is the corneal honeycombing, and the good thing is that it doesn't seem to affect the vision, and this disappears after stopping the ROCK inhibitors. Now, surgery in small eyes. See, you have a crowded anterior chamber. You would always want a deeper anterior chamber. So use of mannitol, 100 ml, 20% mannitol given about an hour before surgery deepens the anterior chamber depth. So do you have to use 100 ml or 200 ml? See, 100 ml and 200 ml or more produces the same amount of anterior chamber depth deepening, but you use more, then it acts faster. So maybe intraoperatively you have that pseudo expulsive sort of a thing where the eye hardens up, where there is fluid misdirection and all. In those cases, maybe you can use higher volume of mannitol, then wait, see if the AC deepens, and then put the intraocular lens in those cases. So that's it. And now let's consider what is the effect of cataract surgery on glaucoma. See, on two things to be considered. How does it influence CME, and what is its effect on intraocular pressure? Studies have shown that the CME incidence is much greater in eyes with glaucoma than in eyes that doesn't have glaucoma. And this higher incidence of CME is much more seen with eyes which have on them prostaglandin analogs. So how does prostaglandin analogs, how does cataract surgery induce CME? So you have the prostaglandin analogs released because of the trauma of surgery from the corneal the lens epithelial cells, and so this prostaglandin that is there in the aqueous leaks into the vitreous and breaks the retinal barrier and causes cystoid macular edema. But see, it is not that the prostaglandin analogs directly influence the blood retinal barrier. It is rather that it prolongs the production. There is endogenous prostaglandin production there. So this prostaglandin analogs act on whatever is produced there. So that is why you don't get CME in eyes without any cataract surgery. So, but there are a lot of studies which have shown that prostaglandin analogs can cause pseudophakic CME. So should we stop prostaglandin analogs for cataract surgery? See, you'll all agree that the modern phacoemulsification doesn't cause a huge lot. I mean, it's effectively atraumatic. So it doesn't cause a huge lot of prostaglandin release. And also there are some studies which show that, I mean, see, intraocular pressure per se, if the IOP is high during cataract surgery, then that influences CME production. So now let's consider that we have decided, okay, based on the evidence, we are going to stop prostaglandin analogs. So when will you do it? See, once it is stopped, whatever you are replacing it should, its maximum action should be reached by the time you go ahead with cataract surgery. So if you consider the antiglaucoma medications, fastest acting is pilocarpine. But obviously, even if the patient is already on pilocarpine, you're supposed to stop it at least 72 hours, ideally weeks before cataract surgery. So pilocarpine is out. Now, the other one that acts fast is a topical carbonic anhydrous inhibitor. It acts in 1 week. But you all know that it's not strong enough to replace prostaglandin analog. All others take about 4 weeks to act. So the switch should be made 1 month before cataract surgery, not 2-3 days before cataract surgery. Another issue to be considered. I mean, if you replace it with brimonidine, even you want a quiet eye during and after surgery. Brimonidine induces allergy. Do you want that to happen? No. And timolol, it's strong enough to replace prostaglandin analogs, but it has a lot of systemic complications, and most of these old patients are already on some systemic beta blockers, and timolol won't be acting as well in them. So, and another issue to be considered, you're stopping prostaglandin analogs to prevent its action to induce the inflammation, that action on the endogenous prostaglandin analogs. So if you see how long it takes for the effect of prostaglandin analogs to wash out, this study has shown that it takes about 4.4 weeks. So if you're basing your discussion on that, the prostaglandin analog should be stopped at least a month before cataract surgery to prevent its CME-inducing effect. But this wash-off effect is for intraocular pressure. The prostaglandin analog actually acts on the extracellular matrix of the ciliary body, and that is how it acts. Maybe we don't have evidence that it's going to be there in the aqueous for a long time to be CME inducing. It could be that the basic action on the extracellular matrix is that it's helping maintain the intraocular pressure low for a long time, even after the stoppage of prostaglandin analogs. So, and another factor to consider, that some studies also showing that prostaglandin analogs don't induce CME after cataract surgery. So this also has to be taken into consideration. Let's come to this survey report published in 2020. They analyzed all these studies, and they said there may be an increased risk in CME with the use of prostaglandins in cataract surgery, and they suggest that non-prostaglandin analog IOP lowering topical medication should be used at physician discretion following a risk-benefit assessment. So should we start prostaglandin analogs? Yes, if you're sure that you can control intraocular pressure with alternative anti-glaucoma medications, and if you can wait 1 month after cataract surgery. Yes, yes, if the patient is at high risk of CME, including those with post-uveitic cataract, CME in the other eye, retinal vascular diseases, high risk of PCR. Like if you have a PPC, you know that there is a chance of PCRN. And definite answer that I can give is stop prostaglandin analogs post-operatively in complicated cataract surgery. That's a definite yes. Avoid prostaglandin analogs for post-operative intraocular pressure spikes. Now coming to the effect of cataract surgery on intraocular pressure, studies have shown that following cataract surgery, intraocular pressure drops by about 4 millimeter, and the effect lasts for several years. The higher the IOP, the lower the drop that happens after cataract surgery. And a few studies have shown that you can reduce the number of anti-glaucoma medications after cataract surgery. So the question, can you reduce the medications post-operatively? Yes, but the decision should be based on the level of post-operative IOP and the degree of optic nerve head damage and nerve fiber loss. So to conclude, the perioperative intraocular pressure is of critical importance for best visual results post-cataract surgery. The intraocular pressure may drop after cataract surgery, but one should reduce the anti-glaucoma medications post-operatively after proper evaluation only, and long-term follow-up is required. Topical prostaglandin analogs, if the patient is at high risk of CME, stop prostaglandin analogs, and ROCK inhibitors may be used for endothelial protection. And topical copper inhibitors, it doesn't adversely affect the endothelium and may be used perioperatively. Thank you.
Thank you, Dr. Srini. The next will be Dr. Vanathy. Dr. Vanathy is a professor in All India Institute of Medical Sciences in the Department of Cornea and Refractive Surgery. She'll be talking about topical steroids and NSAIDs.
Thank you, Dr. Srini. It's nice to be part of this really interesting course, and I should congratulate Srini for crafting it out so well, something which commonly toys on our minds. All of us are prolific cataract surgeons here. So I'm going to speak to you on topical steroids and NSAIDs, the choice, frequency, and duration, no financial interest. The basic know-hows, I think Srini has already covered here. So what you would probably want to know is that ocular steroids exert their anti-inflammatory effect by inhibiting the phospholipase A2 and thereby inhibiting both the cyclooxygenase and the lipooxygenase pathways, and have a propensity for elevating intraocular pressures, especially in eyes which are predisposed or eyes which are steroid responders here. So I wouldn't go on more into the molecular basis of these medications, but one interesting publication which has recently come out is which talks about the penetration of topical and subconjunctival corticosteroid therapy into the human aqueous humor, and what is the therapeutic significance when you look at this. So when a variety of available topical ocular corticosteroids were used on the highest aqueous concentration within 2 hours was looked at, and was seen which one maintains this concentration. And as you could see in this graphical representation, what we can see is the prednisolone acetate is the one which achieves the highest concentration in the aqueous on installation, and a very rapid achievement of the aqueous installation. So that itself is something which tells us the pred acetate is probably going to be the one which we would all want to use in terms of being able to achieve good control of intraoperative or inflammation control in the anterior chamber. So now let us look at what are the various medications we have in our armamentarium to put to use to control the ocular inflammation, the surface inflammation, and the anterior chamber inflammation. I think we all know about all the medications: loteprednate, difluprednate, fluoromethalone, prednisolone acetate, and phosphate combinations, and dexamethasone and betamethasones. So largely what we do use in our practice now is prednisolone acetate and versus phosphate. And difluprednate is the newcomer, and we are always debating on whether we want to place the difluprednate against the use of prednisolone acetate. Loteprednate and fluoromethalone are largely what are known as low potency steroids or ocular surface steroids, largely because their intraocular penetration is not so good, and they are effective in achieving therapeutic efficacy on the surface of the ocular of the eye here. And betamethasone is largely one which is used in dermatological practice. We do not use much of it in ocular practice, and we do want a very potent ocular surface effect. We would resort to dexamethasone. So that said, that's the basis on how you would go about choosing your medications here. So what, as I already mentioned, is would you like to use difluprednate against what we conventionally use for cataract surgery, which is prednisolone acetate here. So prednisolone acetate here, being an acetate here, the penetration is much better as compared to the prednisolone phosphate here. So that itself scores it when you're preferring to control an eye with a greater amount of intraocular inflammation. And as Srini rightly pointed out, today's cataract surgery is largely inflammation-free. I think the scenarios where you would probably be looking at anterior chamber flare and cells beyond 2+ in uneventful or uncomplicated scenarios is much less here. So a prednisolone acetate works well. Again, this is a nice table here which looks at what is the anti-inflammatory potency in vivo and in vitro of the various ocular topical steroids which are available. And this clearly sees, look at the right column here, the right extreme, which talks about the in vitro potency of these medication, and you would see that difluprednate scores much highly over most of what we have here. But that's in vitro, so when you're looking at it in vivo, they are almost comparable, but still the leader being the difluprednate, and what closely follows is going to be our prednisolone acetate in terms, because it achieves a much better concentration. I think these are many of these are RCTs and systematic reviews and meta-analysis are freely available on the internet, and I would urge you all to go back and look at it if you want to have a greater understanding. But in the interest of time, we probably will not go into it. But according to the recommended current guidelines, which are recent, in patients undergoing cataract surgery, when you're looking at topical anti-inflammatory used, the main aim is to control the inflammatory response, and two is to treat established cystoid macular edema. So these are the two concerns for which we would probably want to think about using topical steroids or topical NSAIDs in our patients here. So what are the tenets, or what is going to be guiding us, or what's going to be the protocol in the use of ocular topical steroid therapy? So this is a nice step ladder which I've just laid out for you to understand. And when you're inducing, or with the induction of topical steroid therapy, use the strongest always to control the inflammation. Again, many of us tend to taper fast. Remember, there would be a rebound effect here. So taper only once your inflammation is controlled optimally, maximally here. And once you've controlled, then you can go in for a faster taper. Maintenance therapy, probably use the minimum effective strength and dose that would work well. Adopt a custom approach depending upon the type of ocular surface or the type of cataract which you are, the type of eye you are dealing with, and that is going to have you probably will add on a custom component to this. Monitor the high-risk eyes for adverse effects here. So that's something a cataract surgeon needs to be keeping in mind. See, 9 out of 10 surgeries, you probably need not to apply these protocols, but there is that one surgery which probably can land you up and give you a headache. So that's when you probably will have to know about what are these problems here. Preoperative prophylaxis of steroid therapy or NSAIDs, again in predisposed eyes here. And the synergy with topical steroids, whether you want to use NSAIDs alone or whether you want to use NSAIDs in combination for steroids for control or for management of cystoid macular edema in predisposed eyes, is something which is on the annual and which is being highly debated this year. So now with these said, I'm going to move on to talk about the various NSAIDs which we have with us. So what are the NSAID complications? It is SPKs. You have punctate keratopathies here. You can get epithelial defects and you can get corneal thinning. But this said, again, you don't see it in all ocular surfaces. You only see it in ocular surfaces which are going to be compromised. And when you're going to adopt cataract surgery in such compromised ocular surfaces, you're probably going to pay a lot of attention to this particular. So in the high-risk groups, meaning diabetic ocular surfaces, previous herpetic diseases with corneal scarring, in the presence of severe dry eye disease here, patients with prior Bell's palsy, rheumatological disease are the high-risk patients in which you're going to, there's going to be a warning bell, then you're going to use NSAIDs on these surfaces. Preferably avoid NSAIDs when you're looking at or doing cataract surgery in patients with sarcoidosis, rosacea, chemical burns, irradiation, history of irradiation, ocular GVHDs, neurotropic ocular surfaces, large epithelial defects, keratitis, ulceration. So almost the group overlaps each other. So just for making it easy, you could put the pool in the group together and be aware when you're going to use NSAIDs on this kind of a scenario. Again, prescribe judicially where you probably need to use your NSAIDs in terms of wanting to prevent postoperative CME here or to treat postoperative CMA. The recommendation is you would use it for 2 weeks here and do taper it as far as this, as soon as the cystoid macular edema heals here over here. And if you need to use them over a period of 2 weeks, please schedule a follow-up as frequent as 6 weeks, especially in eyes which are compromised here. So that is the international recommendation here. Again, remember, NSAID uses for postoperative CME is an off-label usage here. So you would want to use them in those cases where, or those eyes which are predisposed to the occurrence of CME. That is when there is an increased iris and intraocular lens touch here, chaffing, which causes chaffing where the iris is adherent to the wound when you have vitreous in the wound and there's a continuous vitreous pulse. These are the eyes which are going to be predisposed or which are going to have a higher incidence of cystoid macular edema here. And a minimal non-therapeutic dosage is probably something which you'd want to use for a long period of time in terms of the ocular surface effects which these medications might have. But beware of the risk of corneal complications here. And again, to emphasize, what is recommended as a protocol internationally is a 6 weeks therapy, beyond which frequent follow-ups here. Again, be aware of poor healing responses when you're using NSAIDs. That said, again, it's not going to happen in all the eyes, but you're looking at with compromised eyes, you probably will be wary of wanting to use, be careful of wanting to use these NSAIDs or steroids for a longer period of time. In the interest of time, I'm not going to go into all these studies. I've sort of summarized these into what is available when it was a good learning experience for me as well to review the literature on this. And this is what I found about 10 to 14 studies is what I looked at. And largely what what plays on our mind is, I already talked to you about the steroids, but when I talk to you about NSAIDs, what we are largely looking at is Nepofenac versus Bromfenac. That's what is going to be playing on your minds. And I do not allow the company people to bombard our minds or to guide us on what we need to use. Please always think for yourself and think what works best for your patient here. But by and large, the Cochrane study, which came in 2017, places us or makes us understand that whatever we have till now, the evidence is probably insufficient to prove an equivalence or superiority of using either NSAIDs alone or in combination over steroid usage. But when this is for ocular inflammation, but when you're looking at the control of the risk of CME, is definitely lower when you're using NSAIDs, or you can prefer to use them in combination with steroids. So I still feel using NSAIDs in combination with steroids is probably the recommendation, though evidence is not pointing much on its things. That said, these are the earlier studies from 97 to 2017. Beyond 2017 to 2022 is when we had the advent of Nepofenac. We have varying concentrations. I think different companies bring different combinations to you here. Bromfenac also comes as a different combination. But the current evidence based on these studies, again, these are not largely comparable because each of them have a different methodology. Each of them have used a different topical application pattern and a different percentages here. But Nepofenac 0.3% is largely what is scoring, and Bromfenac seems to probably have an equal efficacy, Bromfenac 0.09%. So these are the two players which we are seeing in what's available to us of late, but please always be aware of the complications in eyes that are predisposed to affection because of poor ocular surface. I think I'll stop here and thank you for your patient hearing.
Thank you, Dr. Vanati. That was quite exhaustive. Now I request Dr. Prabhushankar, Vitreoretina, Head of Department Vitreoretina, Shankara Eye Hospital, Coimbatore, to talk about anti-VEGFs during cataract surgery.
Thanks, Rini, for the invite. So use of anti-VEGF in cataract surgery. So choice and timing. There's always confusion. We have a hard cataract. Fundus shows there some hard exudates in the macula, whether it's a DME or not. Your patient has old BRVO, and patient also have a CNVM. So we're not sure. So indications for anti-VEGF injection in cataract surgery is usually we combine it in patients with CNVM, macular edema, two scenario. Either patient could have a diabetic macular edema or a vein occlusion. In some cases where the cataract is very hard, fundus is not seen, and B-scan shows some evidence of vitreous hemorrhage, but no RD. That's a condition where you can always combine cataract surgery with an anti-VEGF injection. So the concern with performing cataract surgery in patients with diabetic and macular edema is the potential risk of transient worsening of edema after surgery. This is because there's increased inflammation and breakdown of blood-retinal barrier post-cataract surgery, and it's been noted that the VEGF following cataract surgery is peaks in the first 1 day, go tenfold, and by around 1 month it tapers down. So there's an increased activity of VEGF for the first 1 month of cataract surgery. Probably that's a place where we need to use the steroids also. And angiogenic inflammatory mediators play a role in cataract surgery. may increase the vascular permeability, and which match, patient already predisposed to macular edema, it can worsen the macular edema. So common scenario for referral for retina specialist in diabetic patient is to rule out DME. So you see a few hard exudates and the cataract surgeon is really confused whether to go ahead with the steroid injection during cataract surgery or anti-VEGF, or do cataract surgery and later do the injections. So one of the indicators for, a few of the indicators for visual prognosis following cataract surgery in diabetic patients is whether the macular perfusion status, whether there's a pre-evidence, there's the presence of macular edema, and the stage of diabetic retinopathy. So according to the DRCA network protocol Q, the incidence of developing macular edema post-cataract surgery in patients without preoperative diabetic macular edema is very low. However, presence of a non-central DME immediately prior to cataract surgery or history of DME treatment, be it laser or in previous intra-intervention, may significantly increase the chance of developing a post-macular edema following cataract surgery. So it's an interesting meta-analysis showing anti-VEGF injections in cataract surgery. So they've compared non-peripheral retinopathy, NPDR, without DME and with DME. So they've compared two injections. One is bevacizumab, that is Avastin, and the ranibizumab, that is Accentrix. So what they found out is the Avastin effect is usually around 1 month, but when they use ranibizumab, that effect is always close to 6 months. So in this study, they've said the mean number of injections was higher in the Avastin group, that is the bevacizumab group, than the ranibizumab group. So timing, when to give the injections in a patient, when diagnose that patient has a DME, they divided this group in 3 groups. The first group received ranibizumab 2 weeks prior to surgery. The second group received ranibizumab intraoperatively, and third group received 2 weeks postoperatively. There's one article where they measured the VEGF level, and they found that it's the peak effect of VEGF is around 10-fold in the first postoperative day, and slowly tapers around 1 month. So the best ideal time is, so intraoperative injection of anti-VEGF was found to be more effective than pre or post injection for diabetic macular edema. So the word of steroids, IVT is best combined, as intravitreal triamcinolone is best combined during a cataract surgery because the risk of cataract formation and IOP is less when we compare when you do together than giving it preoperatively then performing the surgery. One interesting study on DexCat study, that is intravitreal dexamethasone implant given 1 month before and combined are used during the cataract surgery. So what they demonstrated is whether you give it 1 month before or during cataract surgery, the effect almost same. The only advantage is usually the macular edema is likely to start around 4 weeks, then peaks around 12 weeks, then fades off. So the best time to give a DEXA implant is combined approach, that is giving a DEXA implant during cataract surgery than giving it prior to a cataract surgery. So patients with pre-existing PDR, so you know a patient has little vitreous hemorrhage, some tractional bands. So ideal is if you're able to do a minimal PRP, you can do it. The lens opacity precludes the preoperative PRP. So you can always compare anti-VEGF during cataract surgery. And following the cataract surgery, you can always do your PRP, whether it be it by indirect or using 90D, you can do a PRP following cataract surgery. To eye with neovascular glaucoma, or you will see a lot of rubeosis, patient has a dense cataract. So it's always better to inject the anti-VEGF agent so that there's NVA negation, and phacospectin can be considered post-injection because the incidence of postoperative hyphema and raised IOP is less when you give the anti-VEGF prior to the cataract surgery. The interesting article is a Monk et al. Method. In case you've done a cataract surgery and there's edema around 4 weeks, so how to differentiate whether patient has developed the edema only because of the cataract surgery or patient had some amount of pre-existing diabetic macular edema. So this OCT shows that sometimes both OCTs look similar. The only catch is we have to look at the outer 3 retinal bands. There's always a disruption of the photoreceptor layer in diabetic macular edema, whereas in the pseudophakic cystoid macular edema, the photoreceptor layer is intact. So this gives a clue that probably is more of pseudophakic cystoid macular edema than a diabetic macular edema. So phaco in patients with CNVM, there's always a concern about cataract surgery being performed in patients with AMD. There's a perceived risk of exacerbation of leakage and submacular hemorrhage, and a predisposition towards other non-macular complications such as retinal detachment and increased intraocular inflammation. So there are two reports. Report 5 on ARS2 study showed that cataract surgery improved overall mean visual acuity in patients with different grades of severity of the AMD. And Rosenberg et al. Showed that when patients in the study, in the trial, who received cataract surgery while on treatment with ranibizumab had an increased visual acuity gain of more than 10 ETDRs line. So there's another article saying that's showing that the safety and effectiveness of cataract surgery and simultaneous whether it give anti-VEGF along with exudate ARMD. In this article, they concluded that the visual acuity does improve even if patient has an exudative AMD. So timing, they have compared a lot of timing, like whether to give it during cataract surgery or 2 weeks post-cataract surgery, but the results are almost the same. But they've said that it's ideal to always combine it with the cataract surgery so the patient avoids 2 procedures. So patients with recently stabilized choroidal neovascular membrane received an injection of ranibizumab, bevacizumab 1 to 2 weeks before cataract surgery. The advantage of this is giving a prophylactic preoperative anti-VEGF stabilizes the potential subclinical choroidal neovascular activity and minimizes the risk of hemorrhage and edema post-cataract surgery. So combined procedure doesn't seem to aggravate the choroidal neovascular exudation, and there's always a mean BCVA. There's more of 10 letters gain compared to a 2 letters gain. So it's always not necessary to maintain a dry retina. So sometimes in chronic CNVM, there's always some amount of fluid there. But when you feel that patient has received adequate injections, you can always go ahead with the cataract surgery, but always better to give 1 injection during your procedure. So in patients with vein occlusions, combined therapeutic approach did not cause a worsening of macular edema in patients with BRVO or also CRVO. There's always a improvement in visual acuity. So patients with cataract who are actively managed for macular edema due to RVO and anti-VEGFs, they can undergo a cataract surgery. Definitely there will be a transient increase in macular edema post-cataract surgery, but resolves without adjusting the frequency. That is in patients who are receiving monthly injections or twice monthly injections for routine vein occlusions. So you don't need to adjust the dose. In case you have planned to do a cataract surgery, you can go ahead with the cataract surgery, but patient will receive a regular routine dose of the anti-VEGF and doesn't affect the vision of the patient. So only caution is we do use a lot of anti-VEGFs like be it bevacizumab, ranibizumab, and efablessib. And the new drug is the brolucizumab. The only concern is that is a lot of foreign literature has reported that a lot of intraocular inflammation and retinal vasculitis. But Indian literature till date has not shown so much of results as the Western literature. But always better not to combine this drug when you're doing a routine cataract surgery, because post-cataract surgery, if patient develops reaction intraocular inflammation, you really don't know whether it's the drug which is causing the inflammation or with the cataract which is causing the inflammation. So better avoid the drug during a cataract surgery. So choices, there are several drugs to whether in case you take a DME, there are several drugs. The only thing advantage of using bevacizumab is it's a lower cost. The efficacy also is good, and also the results are always comparable to your Accentrix or ranibizumab. So advantages of combined therapy is there's a better fundamental visualization for further management of the retinal procedures, no additional procedure, the visual results are always better, and higher patient satisfaction rate. Thank you.
Thank you, Dr. Prabhushankar. It's probably better that I do the intravitreal injection during my surgery than leave it to Gopal to do it, right? Okay. The next, Dr. J.K. Reddy, unfortunately, could not be here, but his presentation will be done by Dr. Umesh. It will be on improving patient satisfaction, management of dry eye, and dysphotopsia.
Yeah, thank you, Srini. Dry eye, I think now has become very common, and I would like to spend a few slides on the classification of dry eye. All these years we were getting very confused and bombarded with the various classification protocols. At last, the Asia Dry Eye Society, the DUSE 1, DUSE 2 is now gone. Now they have come up with this new classification based on the instability of the tear film and the amount of ocular surface damage. Luckily, with this, you don't need any fancy instruments and all these things, including osmolality and all these things. They are classifying dry eye based on the tear film breakup patterns. If you see here, I mean, this is just the beginning. We are just starting to see this. I think all of us must start looking at it. All it needs is a fluorescent strip and 10 seconds of us to observe the blink patterns. And you see the blink patterns. If you see a area breakup or a line breakup, it is aqueous deficiency. A spot breakup or a dimple breakup, you know, it's mucin deficiency. And a random break is lipid deficiency. And that's when correlated clinically, especially with the presence of MGD or, you know, your other dry eye syndromes. So the classification much easier. So now at last there is some sanity in the classification, but important is that we have to get used to the blink patterns. It's not so easy. I'm sure over a period of time we'll all get used to all these things. And you know, when you know that it's an aqueous deficiency, you use your regular HPMCs, CMCs. The mucin, you have newer drugs, ribapamide and your diaquasols. And the lipid deficiency, of course, the more viscous ones like sodium hyaluronate, your polyglycol and HPGAR, and all these things. So at least there is some classification as to what you're using rather than what the representative tells you. So with this preoperative planning, it is imperative that you optimize the surface. First, you identify what is the type of deficiency and then optimize, because it's very important. If it's severely dry, you will end up in miscalculations in the IOL, especially toric, and ultimately and multifocals, especially those who are doing plenty of multifocals. I, for one, do a complete dry eye examination as part of a routine multifocal workup. So make sure that you're going to do that. It is very well proven beyond though that surgery itself causes dry eye to some extent. That is by repeated drying irrigation. The eye drops, the biggest culprit is the back, that is the benzalkonium chloride. And the phototoxicity, especially people doing topical nowadays, the surgical trauma, and of course the incisional nerve damage. So along with that, a pre-existing, so it's better you optimize. The ACRS clinical recommendations has asked us to thoroughly look into all these things they've given. At the end of the day, I think it is our clinical perspective that what we do. So look at the MGDs, mainly at the MGDs and the leads, and any abnormalities in the leads will go a long way, including our good old Oroplus and all those things will go a long way in managing the pre-existing DEDs. And practical tips to manage dry eye disease is, Dr. Manati clearly told us about the NSAIDs avoiding in all these things. BAK, the biggest culprit, use as much as benzalkonium-free containing drops. We'll discuss about it. Artificial tears, obviously, and pre-op antibiotics for any intra-operatively. They do insist that you continue with the two-step iodine because that is proven beyond doubt that it is the best antimicrobial prophylaxis. Limit the amount of anesthetic drops that we discussed because it causes the surface damage, epithelial toxicity. Limit the amount of mediatic drops. So probably you can go more into intracamera's if you have the habit of microscope light exposure, large corneal incisions, questionable flax again in their questioning. Limit the thermal energy delivered, optimize your pharmacodynamics, use the remaining viscoelastic on the cornea at the end of the surgery. That mostly for all surgeries we are doing, and be cautious with the multifocal that we discussed. The post-operatively, obviously, the NSAIDs are avoided, and more the epithelial toxics like the aminoglycoside, all those have been. And follow-up of DED, many times we see that after 1 month or 2 months, they come back to you after 3 months, 4 months, because they would have stopped the dry eye treatment. Make sure that you go ahead with this and increase the frequency of follow-up. See, the post-operative protocol that I follow is essentially Vigamox, no financial interest, but that's the only preservative-free drug that we have now. And I prefer Madam told dexamethasone is a better drug because that's not a suspension, it's clear. And most importantly, if you look at the preservative. It is not doesn't have BAK. It has chloronitrite. That is the preservative, and is more epithelial friendly. Both the dexamethasone and the preservative is more friendly. So I prefer dexamethasone, dexorinase, that is the this one, along with so this is the least amount of BAK that you can actually use postoperatively. And for those severe cases where the Schirmer's is less than 5, and especially the aqueous deficiency, though the recommendation is to go for a scleral punctum flux, I don't believe in that, because that itself will cost you 10,000-12,000, and most importantly, that starts protruding and gives a very bad post-operative touch and all those things. So we do the simple Bowman's cautery with a Bowman's cauter, or here we are using the radiofrequency, simple one punctum closure on table. That goes a long way in at least using the residual tears. So that is about this one. I'll be talking about the dysphotopsias. Now, dysphotopsias has now slowly entering into all our practices. At one point, we were all thinking that best clear cornea, IOL in the black, round rexis. We have given the 6/6 vision. The patient comes back to you and telling you that he has some side vision problem, some blind spot on the temporal side. So, and it only seems to happen in people who have perfect surgery. So now all your life you end up training this, and suddenly now you have to deal with this. Many of these patients, you have done the best, and nothing best can be done beyond this. They come and they are very incredibly happy and telling that I have something here, something is there. So now all of you who are doing the perfect surgeries, you should start dealing with them. How to manage these people. Yes, they are the negative dysphotopsias and the positive dysphotopsias. The positive somehow luckily are short-living. They just have some glare, halos, only in a few patients, persists in some people, but many people, looks like there will be some neuroadaptation, and patient gets this one and gets used to it. And if you look at the actual cause for it, it is because of the total internal reflection at the periphery. So that is the positive. So whereas coming to negative, because we are not bothered, because most of them, once you give some sort of an assurance, they go back. But the negative dysphotopsia now is slowly creating a lot of problems. This is the typical, this is the diagram what the patient has described, that he sees temporarily this arc and restriction, they're telling. 6/6 vision, very good, everything is good, and you will have to spend more chair time in trying to convince them about what this is and what this is not. It happens in the first visit only, and somehow the patients are not happy because you are telling them it's the best, and they are telling that they are not happy. So that is where you need to spend more chair time and try to explain to them. And here what essentially happens is, in the periphery there are two types of blind spots that are happening: zone 1, zone 2, zone 3. There is zone 3 which goes at the periphery from the posterior, and the square edge is where it get distracted here and forms the blind spot. So the nasal rays which falls on the temporal rays which falls on the nasal, many theories have been given by the pioneers, Samuel Mascott, Holliday, everybody. They've been looking at it because they are the first to highlight this problem. And the causes were we started telling them, because we made an incision here, section edema, but the culprit looks like is the more of the optics of the IOL posterior position, the more posterior, because I'm sure many of you would be using the hydrophilic lenses or the rigid lenses where the A constant is 118 or the AC IOLs. None of them complain of any of this. So it's more of the vault, the posterior positioning, which exposes the temporal retina, and the more anterior position of the temporal retina. The most important thing is that what Muscat explained is it can occur only with any lens that is well placed, well within the blank, which is the must that all of us have been trained and doing all our lives. We learned all our lives. So luckily most cases do fade away. So what Muscat said was anything that will block the source of light on the temporal side, like a pair of spectacles, will reduce. So I think all of you must start giving them, wear some sunglasses, and these are the typical sunglasses that you must. Probably he must be having that, I don't know. So the treatment is Muscati. What he said was, this is the nasal, this one, a capsule. So do a YAG exactly there, but the symptoms were not reducing. He said that patients are happy, whether it was because of that or the patients got adapted, we don't know. Piggyback IOL, reverse optic capture, bag in the lens, I think the Swedish lady, I think bag in the lens IOL, I don't remember her name. And then obviously the IOL exchange, I think all these are pretty very vague thing that we have to do, especially when you know that you've done the best surgery. So all of us are now looking at IOL designs. So where is the problem? The problem is we have to eliminate the gap between the pupil, iris and the IOL. How? Either by increasing the size of the IOL or designing the optics. That is what we are also looking at. We are doing a few studies. Some of the newer IOL, this is the Musketeers IOL, which has received FDA approval as of now. The optic has a small groove here, exactly there, where the intercapsule has to be fixed so that the intercapsule is slightly pushed more anteriorly, and that will prevent some amount of temporal dysphotopsia. There is one by the Rupchan, I think this is the Indian version, where he's increased the horizontal diameter of the lens. And this is, I think, Sri Ganesh's, it's an hydrophilic lens with some side swiveled optics, which he lifts and puts on the intercapsule so that the lens essentially comes forward and blocks the nasal cells, nasal ray of lights. Now, what we are also looking at our center is we are trying to look at trying to make the regular lens are usually biconvex lens. So what we are trying to do is make the periphery, the center is biconvex and the periphery concave, so that the rays of light avoid the blind spot. This is exactly, if you can see here, this is the regular lens biconvex. We are making the periphery biconcave, so the rays of light, instead of going there, go there and avoid making the blind spot. And we are actually started a few cases and we are patent pending. And this is one of such lenses that we have started using. But essentially it's a hydrophilic lens as of now, and with a central central biconvex with a peripheral concave. I think going forward, if you really want to avoid this negative dysphotopsia, some IOL designing factor has to come, otherwise it's very difficult to manage these. Either they get adjusted or they stop coming to you because you start charging them more, so either of it. So thank you once again.
Thank you, Umesh. That was really wonderful. Next, we have Dr. Gopalas Pillai. Dr. Gopalas Pillai is a professor and HOD of Ophthalmology Department in Amrita Institute of Medical Sciences, Kochi, and he's also General Secretary of Kerala Society of Ophthalmic Surgeons. And he will speak on medical management of posterior segment complications of cataract surgery.
Thank you very much, Dr. Srini. So we will be talking about managing the medical posterior segment complications of cataract surgery, which basically include cystoid macular edema, light toxicity, macular infarction, delayed suprachoroidal hemorrhage, choroidal detachment, and worsening of DR, retinal vein occlusion, AMD, and finally anterior ischemic optic neuropathy. So these are some points in cystoid macular edema which I would like to discuss, because that's the most important complication which actually makes the patient very, very unhappy. So how do you define? Probably a vision like 20 years back, we would define something like a vision of less than 6/12 with large cystoid spaces around the fovea with a disc leak on fluorescent angiography, a typical flower petal leak on fluorescent angiography, and OCT shows the large cystoid space. So this is such a patient, a very minimal cataract with almost 6/6 parts vision. You can see the retina, which is normal. The fluorescent was done for the other eye because the other eye had some finding. Now this patient underwent an uncomplicated multifocal IOL cataract surgery. Everything was normal, and then he developed this. So his vision dropped down to 6/18. He was very, very unhappy, and this is what happens. But should we change the definition of a cystoid macular edema? That's the question now, because we are looking at not less than 6/12. We are looking at 6/5 or 6/4. We are looking at eagle's eye vision, because you're operating in 6/6. You are going to give them at least better than 6/6. So I think we need to change these definitions. So vision less than 6/6, normal looking fovea, no leak at the fovea. OCT shows some thickening, maybe the definitions needs to change. Okay, so evolving definitions include subclinical OCTs, which means not grossly elevated edema or anything like that, but which will not be associated with significant visual loss. But OCT based edema which is there. Now, how frequent is the cystoid macular edema? That depends definitely on the definition. If it is like the 6/12, the first thing which I said, it will be only 1 to 2%. But when you are looking at angiographic defined CME, it is about 30%. And if you're looking at the OCT carefully in all the patients post-operatively with any thickness of increase in thickness, it can actually increase to somewhere around 50%. So CME is very, very common. And so this is the usual incidence as in phaco with PCIOL, vitreous loss. Definitely the CME chances. This is about clinical CME with huge edema. Okay, so the majority of cases definitely improve spontaneously, but it takes 2 to 3 months, and that 2 to 3 months can be very painful for the surgeon and the patient. Yes. So should we prevent CME at all? So I don't have CME in my hands because my hands are really, golden hands. So that is some attitude with some surgeons, definitely yes. If you do a paracentesis, there's going to be a prostaglandin release. So don't think about uncomplicated cataract surgery not releasing prostaglandins or anything like that. If you do a paracentesis, prostaglandins are released. So situations including CME will be there in every case. We should basically try to prevent CME. And how can we prevent? Basically, we use, prostaglandin is not the only culprit. Okay, there is capsular bag mobility, waves in the vitreous which basically rock the retina, the posterior vitreous detachment. So if, like, for example, there is one thing. Earlier when you used to operate older patients with more maturish cataract, I'm not talking about mature cataract, more advancing cataracts, the age was more, they were already having PVD. But now, as the age of cataract surgery is dropping, and if you're operating much earlier, PVD is not there. So PVD gets induced immediately after cataract surgery. Probably if the PVD is not there, it will get induced maybe in 50 to 60% within the first 3 months after cataract surgery. And that also causes inflammation and other chemical mediators and cytokines which are also come, maybe lens fragments, some peripheral, retained lens matter in novices, not in experienced surgeons like all of you. Okay, so small hidden retained lens matter, vitreous in the wound, iris chafing, these are all classical things which will actually cause gross cystoid macular edema. Okay, now is it very easy to treat CME? We said that about 70%, 75% will resolve spontaneously, so it's very easy. But it is not like that, it will take a little bit of time, so it is always better to prevent also. So cataract surgery having CME, we should always have that stepwise approach and may recur after treatment in some cases. And in chronic cases, you have a little bit of a problem. Now, are we really looking at CME? So that is one problem that you look at, because there are a lot of other mimickers to CME. Like for example, this is a diabetic macular edema which worsened. There's a CRVO which was there. So if you just do an OCT and not dilate and examine, probably you will miss a CME. You're looking at some alternate diagnosis. Okay, so this is an age-related macular degeneration. So this is a radiation maculopathy. So there are lots of other causes of cystoid macular edemas which are not actually post-operative CME. So in these patients, if you continue to give, NSAIDs and topical steroids and NSAIDs and topical steroids, you are not going to reach anywhere. The patient will lose vision and finally end up in catastrophic problems. All right. So what is the role of NSAID and steroid? Yes, there is synergism, and there is a cyclooxygenase pathway, it's a lipoxygenase pathway. Both needs to be blocked, and that is why you require topical NSAIDs plus steroids. Now, there are studies which showed that, combined topical steroids with NSAIDs work much better. This is such a study. In the group 1 where you combined it, there was 0% CME. In group 2, there was 12%. There was only post-operative NSAID. So it's better to always add a steroid. So visually significant pseudophakic macular edema after uneventful phacoemulsification. This is again another study of about 450 patients randomized. And you can see that there is a significant difference between prednisolone alone and prednisolone plus nepafenac here. So that difference is significant. Is there a difference between older NSAIDs and newer NSAIDs? Yeah, newer NSAIDs definitely you have better penetration. Pro-drug activates the active drug, reaches the retina, so better results in CME, which are being shown in a lot of other studies as well. These are studies which shows that the newer, the nepafenac and the bromafenac, no financial interest, but they work much better. You can see all these studies which show they're better. Any use of local steroid? Yes, definitely yes. Subtenon steroids or that definitely helps in a lot of patients, but not initially. A lot of patients can be easily manageable with topical steroids and topical NSAIDs. So look at posterior subtenon, which is very effective in chronic cystoid macular edema, recalcitrant cystoid macular edema, or CME secondary to other pathologies which may actually need intravitreal injections. When to do intravitreal injections? That's a step-ladder pattern, which I will come to. In chronic cystoid macular edemas or other treatments have failed, earlier treatment will reduce photoreceptor damage. That is also one thing. Now you are looking at perfect 6x5, 6x4 vision. You have to have photoreceptors which is intact if CME persists for a long period of time, and if you allow that to spontaneously recover, probably you may have some damage to the photoreceptors. So that requires an individual approach. So step one would be corticosteroids with NSAIDs, then peribulbar steroids. Step 3 could be carbonic anhydrase inhibitors, oral corticosteroids, and step 4 may be surgery if there is a tractional component also. That's the step ladder approach for the management. So some myths which we have burst right now. CME occurs so infrequently. No, it occurs quite frequently. All right. Cost of treating postoperative CME is minimal. You just add an NSAID. No, if it is chronic, you are going in for a lot of problems. CME after cataract surgery will occur no matter what I do, and I don't have the tools necessary. No, we have the tools. We can add steroids and NSAIDs, and then maybe add the other things like it's easy for the retina specialist, may not be that easy all the time. So prevention is always better than cure. Now let us go to some other postoperative complications like light toxicity, prolonged exposure, like especially if a novice surgeon is operating and prolonged exposure is there, definitely there is a light toxicity. Cystoid macular edema can occur, foveal burn can occur, and actually you can filter the light whenever you are suturing, etc. Okay, macular infarction. Sometimes we give subconjunctival gentamicin or something like that at the end of surgery. If there's a PC rent or something like that, you can go inside and cause a massive macular infarction which completely loses vision. Outer retinal ischemic infarction is a rare complication. Selective infarction of the retinal pigment epithelium, that's all very rare. I don't want to go more into it. Worsening of diabetic retinopathy is a very, 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 very common thing. So you need to see if, probably 50% of the patients you operate are diabetics anyway, and maybe 50% of them will have retinopathy. And so pre-operative evaluation and post-operative management of these patients are very, very essential. Inadequately treated PDR will worsen and it will cause bleed after 3 months or 4 months of cataract surgery. Delayed suprachoroidal hemorrhage later. Intraoperatively is a catastrophe which we do not wish to have. Delayed can also occur, usually managed conservatively with cycloplegics and pressure-reducing agents, etc. Choroidal detachment, especially in the presence of hypotonia or wound leak, you look at the cause for choroidal detachment, manage it. It may be surgical. Okay. Steroids may actually build up the pressures as well. Ischemic optic neuropathy, sometimes when you're keeping the bottle at the rooftop and making the anterior chamber stable, especially in labile discs like advanced glaucoma or diabetic discs or some other ischemic areas, you may have anterior ischemic optic neuropathy in which you don't have so much treatment to offer, but then you will try to prevent them in labile discs. Thank you very much.
Thank you, Gopal, for that excellent presentation. That was the last presentation. If anyone has any doubts, you have 2-3 minutes. If not, we'll close the session. Thank you all for attending.